Hello, Calaveras County. I'm Mike Taylor, and you know what? The doctor is in. I know because he's sitting right across from me, Dr. Randy Smart.
Hi, Mike. It's great to be here today.
Nice to be here with you, but I think we're talking about something that we might not want to talk about, but we got to, and that's blood clots.
I think we should talk about blood clots, Mike. Blood clots are a common problem, and they're a potentially fatal problem. Mm-hmm. And we certainly have blood clots in Calaveras County and all over California. And I think the more we can inform our audience a little more about these clots, I think it would really benefit the county.
So I guess we begin with who gets blood clots.
Well, why don't we begin with the plumbing?
Oh, okay.
So
why the blood clots?
So you have a pump, your heart. Mm-hmm. And it pumps blood out through the arteries, mm-hmm. and then it returns through the veins. Now, any of those pipes can have a clot.
Okay.
But there's a very big difference between the clots in the arteries and the clots in the veins.
Oh.
So the clots in the arteries are what we know as heart attacks and strokes. And we could talk about that another time, but in the return system, in the venous system, you can have clots, and those are the clots we should talk about today. The people that get them, the people that are at risk, actually one of the most important risk factors is age.
Okay.
And as you know, Calaveras County has an age demographic that's about 10 years older than the rest of California. Mm-hmm. So we may have even a higher incidence of clots.
Okay.
But somewhere right around the age of 50, mm-hmm. you'll see the clot chart just go right up.
Start climbing right up, huh?
Stays relatively low, 20s, 30s, 40s, and 50. It's like a rocket.
Wow, okay.
Yeah. So one of the most important things is age, mm-hmm. but there are many other things that put patients at risk for clots.
What are some of those?
Well, for example, tobacco.
Okay.
And in fact, there is a triad. I'll get to the triad in a minute. But tobacco is one. Medications actually can put you at risk for blood clots.
Oh.
And so one of those medications is estrogen.
Really? Okay.
And guess what's in birth control pills?
Estrogen.
You got it. Mm-hmm. So if you take one of our patients who is on birth control pills and smokes tobacco, they are at a much higher risk for blood clots.
That's two legs of the triad?
That is sort of all three legs of the triad.
Okay.
Because probably age is thrown in there somewhere
that's right.
as those
mm-hmm.
birth control pill
okay.
users become a little bit older.
Mm-hmm.
But certainly tobacco and estrogen is a bad combination.
I'll be darned.
Yeah, exactly.
And how do we know we've got a blood clot?
Well, it can be difficult. And what I mean by that is you can have a blood clot and not have any symptoms.
Okay.
That would be difficult, right?
Mm-hmm.
Yeah.
Sure.
So more often there are symptoms. Now, most of these blood clots occur in the legs.
Oh, that's okay.
They can occur in the arms.
Mm-hmm.
They can occur in the intestines. They can occur other places, but by and large, the majority occur in the legs. So one of the common symptoms, if you will, or warnings, would be swelling in only one leg.
Oh, okay.
Because
mm-hmm.
as that vein becomes clotted, the blood gets backed up and the leg swells.
Mm-hmm.
So swelling would be a sign. Pain would be a sign. And in my experience, it tends to be kind of an achy, deep achy, kind of a vague pain. It's not a sharp pain.
Not really an ouch, I have a clot right here and
right.
It's stinging me right there on my leg.
Usually not like that.
Okay.
It's usually like, doc, my leg just kind of aches and it's swollen.
Okay.
What do you think could be wrong?
Mm-hmm.
So pain can be, and then redness. If you have redness in the leg, maybe we could call that a triad: swelling, pain, and redness.
Yeah.
Those would be common symptoms in somebody who has a clot in their leg.
And does this have anything to do with, well, obviously with the circulation system, but where I'm going with that is this is in the return. So is this the blood has gotten there and now it's kind of struggling to get back, and maybe that makes things more apt to clog up? Or?
So the question really is, why do people get blood clots? You know, blood is designed to clot. It's important that it clots, because if it didn't clot, we'd all bleed.
Yeah, we'd all bleed from a paper cut. Yeah.
So it's supposed to clot. But there are things that make that a little more likely. Now, you've alluded to one of those, and that's what we call stasis. And stasis is when the blood is a little bit sluggish, not moving so fast.
Okay.
And the venous system is kind of like that. It has stasis in it. But there's other things that create stasis. For example, not moving around a lot. If you were to lay in bed all the time, that makes for more stasis. And in fact, one of the scenarios that is very common would be somebody who is on a long trip. So somebody who gets on an airplane and flies maybe transatlantic or transpacific, or somebody who is on a bus and going to Kentucky, or somebody who gets in the car and drives to LA. So there you sit with your legs doing absolutely nothing.
Nothing.
And guess what people do when they're sitting there doing nothing? I'll help you with this. They cross their legs.
Oh, okay.
Right? You're sitting on the airplane. You're in one of those places where you get no room.
Yep.
We all cross our legs, right? So that makes it even more likely. So,
really?
Oh, yeah, absolutely. So the classic scenario, and I've seen many cases like this, where somebody gets on an airplane, maybe they smoke, maybe they don't, but they get on an airplane, they fly to Frankfurt. They sit on that airplane the entire, whatever it is, 12 hours. They cross their legs, they don't get to move around a lot, they've got a window seat. They get off the plane and their leg is sort of sore.
Wow.
And the next day it's swollen and red, and they don't know why. And that is a classic presentation of a blood clot.
Wow, and so how do we then diagnose it? It sounds like that's not easy.
Well, actually, that's easier than you might think. The first thing you do is you have to connect with a clinician who says this might be a clot.
Okay.
So the doctor or the provider has to have an awareness in saying, you know, this could be a clot. Now, you would think that happens 100% of the time. It doesn't. But that's the first thing. So as a patient, you need to get to a source of health care. And we really regard that as kind of an emergency.
Oh, really? Okay.
And I'll tell you why in a minute. But you need to get to a source of health care, and that's not tomorrow, it's not next week, it's now.
Okay.
And it would be, if you couldn't find a source of care, it's completely appropriate to go to an emergency room for this problem.
All right.
Right. So once you get to the source of health care and the light bulb goes off with the clinician, then we can order a simple ultrasound test.
Oh.
It's one of the simplest tests we do, Mike. And they take the little probe and they move it around on the leg. They find the clot. That takes all of 10 minutes. And they say, that's what you have.
Okay.
So not a complicated diagnostic thing, but it's really having that clinical suspicion ahead of time. And there are actually scoring systems now that can be used, formulas that can be used where you plug in demographics or, you know, is it a swollen leg? Do they have risk factors? And you plug those in. And the scoring system will tell you what the probability of them having a clot is.
Oh, I see. Okay.
Right. So now, let's talk a little bit about why that's an emergency. And that kind of falls under the category of complications.
Oh, from the clot.
From the clot. So you have the clot in your leg. Many of those are no more complicated than that. They stay in the leg. They kind of maybe aggravate you a little bit. Over time, they go away. But many times they can break off. Now, remember the plumbing going back to the heart.
Yeah.
So these clots will break off and they float. And they float up and they stop right where the pulmonary circulation is.
Okay.
Right at the entrance to the lungs. And so that is called a pulmonary embolus. Kind of more colloquially, it's called a PE.
I see.
But it's called a PE or a pulmonary embolus. And that has a definite fatality rate associated with it.
Okay.
So people that get pulmonary emboli can be walking right down the street and drop.
And just drop.
That's it. Drop. Gone.
And that's because that clot has done what? It's lodged somewhere that it shouldn't be, or?
Right, so it gets into the pulmonary circulation, which starts to get smaller and smaller. And so the clot, let's say it's the size of my thumb, it gets to a point where it can't go any further.
Okay.
And then you've just blocked an entire section of lung.
A lung, yeah, okay.
That is no longer getting circulation.
So what do we do about the clot once we've waved the ultrasound over there and we've found it down in the lower half of the left leg? Where do we go from there?
Well, it used to be, and not too long ago, all of those patients were hospitalized.
Oh.
Every single one of them. Because the immediate treatment was a medicine called heparin.
Okay.
And so heparin was given intravenously. And so almost all those patients would spend about 5 days in the hospital.
Oh, goodness.
And about 7, 8 years ago, newer medicines were developed and newer technologies. So now many of those patients can be treated as an outpatient.
Oh.
The treatment is to immediately thin the blood.
Oh, okay.
Immediately thin the blood. And so there are, as I say, there are outpatient medicines that can do that. Now, if somebody has a pulmonary embolus, we generally keep them in the hospital for a couple days because they have a higher fatality rate and we are more concerned about them.
Does the clot show up in, say, or do you have to ultrasound the lungs, or can you see them in an X-ray, or?
Right, there is an X-ray, and it's got a long name. It's called a CTangiogram.
Okay.
Which is a form of a CAT scan, and I think most of the viewers probably know what a CAT scan is. Has nothing to do with cats.
That's right.
And so the CAT scan, there is a technique with IV contrast where you can look at the pulmonary circulation.
I see.
So it would not be uncommon, in fact, it's very routine to find a blood clot in the leg and just do a CT angiogram to make sure there are no blood clots in the lung.
Make sure something else hasn't come up beforehand.
And it's really kind of surprising. Most patients with pulmonary emboli have symptoms, and we could talk about those symptoms a little bit. But I have seen many patients that have pulmonary emboli that have no symptoms.
Goodness, so that's...
They had a swollen leg, they had a risk factor, and then they went to the ER. One thing led to another. They had the CT angiogram, and there were 5 different blood clots in their lungs.
Oh my gosh, and that is literally the ticking time bomb, right?
Absolutely. Absolutely. That can be a fatal event. Absolutely.
Bet.
Yeah.
So as we take the medication to treat that blood clot down in the lower half of the left leg, is that clot literally going to shrink and then break off and the cells have died and gone away, or does it remain some kind of a capsule inside the vein, or?
That is a great question. I wish more people would ask that question. What happens is about 85% of the time that will dissolve. The body will reabsorb that clot. And when you study those patients, I usually study them, about 8 to 10 weeks after the event, and they're on treatment, you'll find no evidence of clot whatsoever.
Oh, wow, okay.
85% of the time. 15% of the time, they have residual clot, or clot that's not going to dissolve.
Okay.
And you're right, it develops a little membrane and a little coat. It becomes very organized. And that clot is probably there for the rest of your life.
And you're okay with that? I mean, you're going to be healthy, or?
Not necessarily.
That's what I was afraid of.
Not necessarily. I wish. So there is a really unfortunate complication from blood clots called post-phlebitic syndrome, which basically means the symptoms didn't go away. And so for years and years, you can have a swollen leg that won't get better, and pain that won't improve, and really be disabled.
Yeah, it sounds like it.
I've seen patients that maybe their normal leg was, not a big leg, and their affected leg was huge, absolutely
goodness.
huge. Yeah.
Wow.
Yeah.
That bad, huh?
But the other thing is that can also happen in the lungs. So with these pulmonary emboli, these clots go to the lungs. 85% of the time they dissolve, 15% of the time they don't. And if you're the 15%, you can have dead lung tissue.
Oh, sure.
And you can have difficulty breathing, and you can become a kind of a respiratory patient for a long, long time from that.
Is there any instance where we go in and want to cut that clot out?
Yes.
Okay.
Actually, there are a couple different things that can be done in a good facility with good people. And one is you can advance a catheter into the circulation, and you can actually grab the clot and remove it.
Okay.
So that can be done. The other thing you can do is you can advance a catheter into where that clot is, and you can use one of the clot-busting medications. One would be called streptokinase.
Okay.
One would be called TPA, but you can actually infuse that clot-busting medicine right where that clot is.
Right at the spot.
And break it up.
Oh.
If you're early enough, and so that's not uncommon. That does happen, and with really good outcomes.
Do you then, when in my brain, when you say the clot breaks up, it sounds like, we just sent a clot toward the lungs to go become a clot, tomorrow. Is that what we're kind of looking at, or?
That can happen, like what you might think of as a shower of small clots. So you can break up that clot either with medicine or mechanically, and you can downstream have many small clots, but the bigger clot is the bigger threat. And once you break that up and it goes downstream, there is much less lung tissue involved and much better outcomes.
And that's because they're smaller pieces.
Exactly.
In theory, moving through the veins.
Exactly.
Now, can you get to a point, say, with someone, and I know I'm coming up with almost a true nightmare scenario, but someone who's got arteriosclerosis, and so the tubes are already kind of full of stuff. Are these kinds of blood clots going to be more dangerous for someone who's got those kinds of clogged, or is it truly the arteries get clogged with arteriosclerosis and it's the blood clots you worry about in the veins?
Right. So the blood clots and the veins actually don't get atherosclerosis, and so the blood clots in the veins don't get plugged or captured because of plaque buildup. But if you had a patient who had that problem, who had atherosclerosis and had maybe some mild heart failure, or even somebody who had emphysema, somebody who had some sort of underlying heart or lung problem, and then you threw one of these pulmonary emboli into that, bad news.
Yeah.
Bad news. So if you take a healthy guy like you and you have a pulmonary emboli, and you don't die within the first 5 minutes, you usually don't have a lot of long-term problems from that. You can survive the physiologic stress. You can get through that, and there are many, many patients like that. But if you take somebody who is kind of fragile and doesn't have a lot of reserve, even a small clot can be fatal.
Wow.
Yeah, absolutely.
Didn't realize that they were, well, one, that prevalent. You occasionally hear, and it's usually, grandma and grandpa kind of talking about maybe getting a blood clot. And maybe that's a good point. Is it more prevalent in men or women, or is it kind of across the board?
Well, I always thought it was more prevalent in women because of the estrogen, and it just clinically seemed more prevalent. And when I prepared for this talk, it's actually more prevalent in men, but not by a lot.
Okay.
I mean, it's almost equal, but just a little bit more toward men.
A little bit towards men.
Yeah.
And so age is a factor. Does obesity, it seems like obesity affects absolutely everything in the body. Can that play a role in this too?
It affects everything.
It affects everything, doesn't it?
But there are some other important risk factors. Cancer. There is something about cancer, and it kind of doesn't matter which kind of cancer it is.
I see.
It could be lung cancer, it could be stomach cancer, it could be brain cancer. But cancer almost increases the risk tenfold.
My goodness, really?
So the people that are much higher risk would be cancer patients. The other people that are higher risk, well, there's actually a couple categories, but one would be people that have had blood clots before.
That was going to be my next thing, is once you get one, are you kind of going to have to be on the lookout for more?
So if you've had a blood clot, your chances of having another one in the next 10 years is almost 30%.
Oh, okay.
So that's 1 in 3, right? To me, that sounds high.
Yeah.
So that's a risk factor, but one of them is genetics.
Oh.
And when I was in training, we didn't understand a lot about genetics and a lot about blood clots. But something like 25% of people that get blood clots have a genetic predisposition to get those clots. So it's something they've inherited from their father or mother. And there are probably, Mike, there's probably 6 of those different kinds of genetic defects. So typically when somebody comes in with a blood clot, and particularly if they come in with a second one, we do all that genetic testing. And we don't do it for them because it's not going to change what we do with them. It's about their family.
Okay.
So if you had a blood clot and you had one of these genetic defects, we would want to make sure your sons and daughters were aware of that.
Yeah.
And could be tested and could be protected. Because preventing these is really what you want to do.
And is there a way to prevent blood clots from forming?
Absolutely.
And what are some of those? Well, it sounded like we were on a dead-end street here.
Don't smoke.
That's true, don't smoke.
You manage your weight. But more practically, if you're on one of these long trips, you need to move your legs.
So
you need to get up and walk around.
Yeah.
If you smoke and you're going to be on a bus going to Kentucky, then staying away from the smoke during the trip is a really good idea.
Yeah, don't get off the bus to have a cigarette. Get off the bus to walk around for a little bit.
Exactly, And we tell patients this. We say, look, we know you're going to London. We know you're going to be on an airplane. By the time you hit the East Coast, or maybe even sooner, I want you to walk up and down the aisle a couple times. And they do it.
Yeah.
I mean, they know and they do it.
Well, good.
We also can medically help these patients when we know they're at risk. Let's say they have a genetic risk or they've had a clot before and we know they're going to be in a high-risk activity like a car ride to LA. Sometimes we'll put them on medications to do that. We'll put them on blood thinners just for the duration of that trip to protect them. And that's a fairly common practice. So there are a number of preventative strategies that are available.
So sort of the prophylactic thinning of the blood when you know you're going to be seated for that long.
Exactly.
Okay.
Exactly. Right. And we really try hard to educate our patients about that. Particularly the ones that have cancer, the ones that have had blood clots before, or the ones that have the genetic. We really sit down and say, look, it's perfectly okay to get in the car for 8 hours or to get on the plane for 12.
Yeah.
But let's talk about how to do that.
Yeah. There's a reason there's a rest area every so many miles along the highway. Right?
That's one of the reasons, yeah.
Now we're getting down to the end of it, so we've told folks your leg is swelling mysteriously, it's achy, doesn't feel good. It's a reason to call the doctor and get in there pretty darn quick.
Absolutely.
Yeah.
If in my practice somebody calls with anything that sounds like a blood clot, we tell them to come in now. It doesn't matter whether it's lunch, it doesn't matter whether it's Friday, we tell them to come in now.
And what's the first thing that'll happen? Is it going to be you'll go over kind of what some of those risk factors might be, and that'll help you decide, yeah, I think maybe you've got a blood clot?
Right. I'll assess them, maybe even use one of these scoring systems. I pick up the phone, call the hospital, and in this case, Mark Twain Hospital, and they say, send them down right now, we'll look.
Oh, okay. So they've got the ultrasound kind of...
They go right to the hospital.
Almost on call.
And it's really wonderful because the hospital will call me back right away and say, it's normal, or they do have clot, they're here, what would you like us to do?
I see. And then if it's threatening to become one of those emboli, hospitalize them, you're right there.
Exactly, Mike.
And you're headed down a better road than you were 10 minutes ago.
And you might have saved a life.
Might have saved a life.
Right.
As far as prevention goes, stop smoking, eat healthy. If you're going on that long trip, do you call your doctor to double check, or is it just...
Move your legs.
Yeah, so move your legs. So make sure and move around.
Loose clothing. Don't cross your legs.
Okay.
And make sure you understand if you have a family history or not.
That's it.
That's it.
So we've come up with it, Dr. Smart. We haven't cured many blood clots, but hopefully you, ladies and gentlemen out there, now know what to do, like we said, when your leg is bothering you for no reason. So the doctor has been in, Dr. Randy Smart. Thank you very much.
You're welcome, Mike.
I'm Mike Taylor, folks. Stay healthy. Go see the doctor once in a while.